Hi, everyone. I'm Dr. Faisel Syed,
And I'm Dr. Dan McCarter.
and you're listening to Faisel Friends, where we believe access to primary care is a right, not a privilege. Today, Dr. Dan and I are talking about healthcare innovation. Let's dive right in.
We've been going live, think about 2 years ago. We were just, we heard about this virus over in China that might be an issue that we were going to be dealing with. And pretty soon after that, we were really dealing with it in a big way. And really thinking about how we could keep relationships going and doing it on social media. And we started the Faisel and Friends, and it's continued to have an audience, and the audience has grown. But now we're seeing that it's more of the podcast audience, so we're making the transition to make it easier to get guests on when we can be more flexible with recording times. But what do you think it's over the last 2 years? What have been the biggest surprises for you, and what are the things you've liked about it so far?
I think my favorite thing about us getting onto social media and connecting with like-minded people who are passionate about why they got into medicine in the first place and how just comfortable they become. We're connecting with these people. Most of the times, the first time that we've spoken with them, we have nothing in relation with them, with their lives, and suddenly we all just connect. We connect, and it just all makes sense. And and I think the timing was right. The pandemic forced many things to happen, and one of the things it forced was that, as a company, we were this. We meet people in person. I mean, we would be in 2 or 3 cities in one day. It was so easy to just hop on a plane, go over here, go meet somebody, hop on a plane, go meet somebody. I mean, we were so much like that as a company, and then the pandemic forced us to embrace this way of engaging with each other by FaceTime and these video calls and video meetings. I think I think that allowed, at least for me, to think more outside of our presentations or our engagements where we'd have 8 doctors, 10 doctors, maybe a couple dozen doctors. To now, we can find there are many people in healthcare delivery, good people who are struggling in a system that was never designed for them. And so, as I think like as we're scaling this model at ChenMed, the neighborhoods we're growing the model in are the same neighborhoods as the community health centers. And I think that getting getting the two of us together, you have the community doctor. Before coming to ChenMed, I'm the community doctor. I had all the unfunded patients and the patients nobody wanted to see, and the academic doctor, ACO doctor, with the experience of leading these large centers and running this large ACO together, speaking and connecting with people from both sides. We're both very passionate about restoring the doctor patient relationship. We both find it just so uncomfortable and appalling and unethical that people are having to make the decision of choosing whether to eat their food or to go see a doctor, pay the copay for the doctor. And we met people along the way, and we learned also along the way. Like, no matter how eloquent, there are many people in healthcare delivery who speak incredibly eloquently about a horrible situation. And then you have us coming saying that, well, it may sound nice, whatever it is you're saying, but at the end of the day, the number one cause of bankruptcy in the United States is medical debt. One in five Americans is in some stage of debt collection due to medical bills. So it doesn't matter how eloquent someone tries to sugarcoat our situation. It kind of reminds me of that movie with this asteroid coming this way, and people kind of sugarcoating and, hey, we're not going to run out of money. We'll figure out a way. And here we are saying, no, the time is now. The time is now. And there's a model that is working. Incredible things start to happen when you get rid of the incentive and you get rid of the stress of billing, especially from doctors. I mean, you look at all the nonsense work that doctors do, and when we connect with people, we see about the main one is all the stress about generating billing. Or then you can get into all the other things doctors have to do with all the documentation they have to do in the computer, all the work with refilling a prescription, or all the work that's required to communicate with an insurance company. We're seeing that, and it's not necessary. And I think this offered people to be able to connect with us and hear, well, how are you doing this? And we're saying, hey, this is how we're doing it.
Right. Well, and the thing, so, and I would even go back a little bit further in our backgrounds, is we both got to train, and who I think are just great role models. You with Dr. Buckholtz at Columbus, Georgia, and me with Lewis Barnett at the University of Virginia. And I think, I think the thing that we see about our out delivering better outcomes, but also about the guests we've had, it's about relationships, and it's one-on-one relationships, and healthcare happens one-on-one, right, with somebody. Everybody who, nobody. I think one of our guests, I think it was Dr. Cochran, said that the wasn't it him that said the role of patient is never one that somebody wants. It's never something that somebody chooses. It's always an unwanted role. And how do we help that relationship, and how do we reach back to this? This was you know, this this was healthcare from the beginning, right? I mean, even before there were antibiotics, it was about having somebody who cared about you. Even before we had drugs to treat people, what people wanted to know was there somebody that cared about me and could give me advice, and that would that would help my dis-ease, my ill at ease. So I that's the thing I found here. It's no matter you know, the Vivian Lee who's working for running one of the big alphabet companies, or the direct primary care docs. I mean, talking about the importance of the relationship and building relationships to improve the outcomes we're getting in healthcare.
When in residency, one of the advantages of training at an unopposed family medicine program is that, when there's like a catastrophic situation, let's just go to the extremes of catastrophic situations. The news, media, and like a lot of the attention focuses on the catastrophe. Like there's that horrible volcano eruption in the South Pacific, and you see all these incredible images from like space, satellite images of this massive eruption, and then all the waves, and seeing videos of the tsunami and all this stuff. Uh, in healthcare and with people, when they're in these situations, they're forced to become a patient. And when you're forced to become a patient with little to no options, it feels like, by definition, like a catastrophic situation. And most people tend to focus on the catastrophe, but there are always few people who are like the ones who are going out there, the paramedics, the medical people. And these people, it's not, I mean, I'm sure there's some of them who want to go into harm's way. I mean, there are, I'm sure people like, but the vast majority of them are are doing it because they feel the need to be there. They feel the need to be the ones who are the helpers, the ones on the side of trying to do whatever they can. It doesn't matter if it's like a plane crash and you see fire, you see people running towards that plane, hoping that they can save somebody in what looks like a hopeless situation. But then those people who go into those dangerous situations, I think they represent hope. And if you look at healthcare delivery in the United States, that is complicated, and it feels even more. It feels like a catastrophe. When you try to understand it and wrap our minds around it, and how can we can make things better. I think the people who are on the side of running into this situation and saying, "Hey, look, we don't have all the answers, but we're going in over there not because we want to, because we feel the need to. Like this is our life function." And it could be running in there to, we could open new centers. We could run in there, bring on more doctors, run in there, bring on more patients, and try to improve lives. But it's also going into academia, going into residency programs, and educating the residents about a different way of how to practice medicine. We're meeting. Remember, we met interns a couple years ago who are memorizing billing codes. That just is not acceptable. We have to be the ones who are saying no. It doesn't matter if the demand on the outside is for them to memorize billing codes. We're family doctors, we're internal medicine residents, or we're geriatricians, whatever.